Okay, now it's time for our last state-of-the-art talk before our Lifetime Achievement Award. And it's my great pleasure to introduce Dr. Mimi Canto, who is a professor of medicine, director of endoscopy, Johns Hopkins University School of Medicine, and she's going to discuss screening patients at high risk for pancreatic cancer. Thank you so much, Dr.
Hi, good afternoon, everybody. I do want to echo that it was such a fantastic summary and comprehensive review. I really enjoyed that. Thank you. So this is a marathon, but I'd like you to hear about where we are now with pancreatic cancer screening. It's actually been more than 20 years we've been trying to understand this. So the objectives would be to discuss the rationale behind screening, to summarize what we know to date about the diagnostic yield and the outcomes, the challenges we still have at this year, and also to propose new ways to improve detection. So why do screening for pancreatic cancer? Well, it always starts with the patient, right? So this is a patient. I'm a trained therapeutic endoscopist, and as a unit faculty, I actually did a palliative stent in this patient in the middle here who had presented with an advanced pancreatic cancer. And I went out after the procedure to talk to her family, her two daughters beside her. And when I talked to them, I learned about their family, and their family actually had 6 pancreatic cancers over 3 generations. And they asked me what they could do for themselves. And at the time in 1998, I had no answer. And it was interesting because over these years, we have developed at least some type of approach that differs from what we're doing now, which is mostly palliative stenting and treatment of symptoms. These 2 individuals underwent screening, and this lady here who was our first pancreatic cancer patient screened had an asymptomatic stage 2 pancreatic cancer, had a Whipple for that screened pancreatic cancer and lived 12 years. This is her brother who also developed cancer and also had detected pancreatic cancers, underwent a total pancreatectomy. So you can really start with the patient and the family and really see how this can impact on their lives. So we have an opportunity because we can actually see some of these pancreatic cancer precursors, and there is also an opportunity for prevention and not early detection. So we start with a pancreatic cancer, a mass that we know and recognize very easily, but there are recognizable precursors such as mucinous cyst adenoma, an IPMN. Typically, pathologically and radiographically, it's defined as a cystic mucinous ductal-lined structure that's bigger than 5 millimeters. And you have the more invisible PANINs, pancreatic intraepithelial neoplasia, which again, pathologically are those small tertiary ducts in the pancreas that are invisible to our eyes. And unfortunately, most of the pancreatic cancers arise from these invisible precursors. So if you look at the pathogenesis of pancreatic cancer, they evolve through accumulation of epigenetic and genetic mutations, which we actually can learn from in terms of how we can actually employ this knowledge about what develops from a normal duct to these low-grade pancreatic PANIN precursors, to more advanced sort of PANIN changes, and to severe changes in the ducts, similar to carcinoma in situ called PANIN-3. We now call it high-grade dysplasia, which again have these more advanced mutations. And you'll see the relevance of this in a minute. So why are the goals of screening? Well, we do want to risk stratify, identify those high-risk individuals who would, with a genetic predisposition at the current time, detect early cancer, or preferably the precursors that are high-grade. And we want to, as much as possible, prevent pancreatic cancer, similar to the way we do colonoscopy and polypectomy in colorectal cancer. And that is, in fact, the holy grail. We do highly selective surgical intervention for these individuals. So who is eligible for screening? This is, again, evolving over the many years, but currently we recommend screening in BRCA1 mutation carriers, BRCA2, PALB2, patients with at least 1 first-degree relative or any 2 blood relatives beginning at the age of 50 to 55. Patients with ATM mutations, again, with at least 1 first-degree relative, and patients with Lynch syndrome, mismatch repair gene mutations, at least 1 first-degree relative, at the same age or 10 years younger than the youngest pancreatic cancer in the family. Those who have no known genetic mutations where these are really rare syndromes, like the familial atypical multiple mole melanoma syndrome, very rare but very deadly for melanoma and also pancreatic cancer as part of the phenotype. There's no affected relative required. And in fact, pancreatic cancer screening should begin at a very early age. These patients have young onset pancreatic cancer. Patients with hereditary autosomal dominant pancreatitis, patients with Peutz-Jeghers syndrome with STK11 gene mutations, which can lead to multiple kinds of cancers, lung, GI tract, cervical, uterine, as well as pancreas cancer, are very, very high risk. And then there's the patients who have individuals that have no known mutation that just have family members affected. And we define these patients as familial pancreatic cancer there's at least 2 affected first-degree relatives in the family. And we screen those who have at least one of those relatives related to them by first degree. So basically a parent, a sibling, or a child. But currently we recommend full panel genetic testing for pancreatic cancer genes, but you can in fact detect an inherited mutation in these families. And this actually affects their risk as well as their management. Why is that? We can see that in this study, we actually compared the outcome of patients with and without a mutation. And you can see that in fact, the risk for mutation carriers is much, much higher than in those without a mutation. And so therefore, again, genetic testing is really important. If there's one thing you need to remember from this talk, please offer genetic testing to your patients. It is much more affordable. It is very available and now than it was 2 decades ago. So the progression may also occur in these individuals after you start screening many years after baseline. This is a Kaplan-Meier curve showing the cumulative hazard for progression in our CAPS cohort many years ago. And actually the average time from a patient to begin screening to when they develop a cancer, if they're destined to develop one, is about almost 5 years. So you can have patients who are undergoing screening and have negative results or trivial results for years before they can even develop some concerning finding. This is an example of one of those patients. He's a general surgeon who referred himself actually to our program when he heard a talk from John Cameron, one of our surgeons, at a surgical meeting. He had 5 affected relatives, and he joined our study then in 2003. He had no lesions, kept coming annually, and basically developed precancerous cysts in the body and tail, developed more cysts. They were all low risk by current criteria. And then at year 10 of his surveillance, he developed this really tiny pancreatic cancer, the smallest probably you'll ever see, without symptoms, negative on CT and MRI, which was proven on total pancreatectomy, which is the operation that he and his surgeon chose to have. How do we screen or survey these patients in general nowadays? Well, we always recommend EUS as well as EUS, MRI, and MRCP as much as possible. We also are now currently recommending screening for new onset diabetes, which is a risk factor in general for pancreatic cancer. On follow-up, they also get typically, usually annually alternating surveillance imaging procedures. We modify that nowadays in patients who have germline mutations, particularly if they have cystic precursor lesions when they reach the age of 60 or older, because there are in fact interval cancers that develop in these mutation carriers. We also screen them annually for fasting blood glucose. And clearly when there's some concerning indeterminate lesion in the pancreas, we also do serum CA19-9 to help us figure this out. Now, the ASGE recently published their guideline recommendations supporting pancreatic cancer screening in high-risk individuals, and it's shown here. But you can see here that EUS may be preferred as the screening modality of choice when patients are at very, very high risk, like Peutz-Jeghers patients, patients with P16 mutations, when you're doing an EGD to screen for gastric cancer and duodenal cancer, for Lynch syndrome, when they have a contraindication to MRI, claustrophobia, metal implants, renal failure, etc. The linear echo endoscope is always preferred. We did a randomized tandem study, radial versus linear, years ago in a multi-center CAPS-3 study. Interestingly, the miss rate for a lesion in the pancreas was 25%, similar to a colonoscopy miss rate when you did a tandem study. And it was much lower though for linear EUS, and so therefore we must perform it using linear. The MRI may be preferred in patients, ideally 3T nowadays. If there's an increased risk for adverse events from anesthesia, patients who avoid invasive testing. When you combine MRI with enterography for Peutz-Jeghers syndrome patients, for example, on the alternate year that they're being screened. Now, what do we find during pancreas cancer surveillance? Most patients that we find, 40 to 50%, even at their baseline, have 1 or more cysts. Again, as I showed you, these cystic lesions are either small or developing IPMNs or pannins. We measure these in all the screening tests. This we did in CAPS-3. We did CT, MRI, and EUS in all 200 something patients that we screened. And you can see here that MRI and EUS detected the most lesions. Most of them were cysts. And therefore, these led to the recommendation for using these 2 tests in tandem for our for our patients. This is an example again for an EUS that shows a very small cystic lesion, very trivial in the tail of the pancreas. This would not meet any concern for neoplasia. And you can see up close, you can see not only is there a cyst, very small, tiny cystic lesion, but on EUS, you can see the pancreatic duct coming over here. You can see these very subtle changes on chronic pancreatitis. We call this lobularity. There's some fat deposition here. And actually, when we started studying these pancreatic from these individuals who had surgery for whatever other reason, you can see here that you can have tiny duct lesions that look like cysts that are very tiny. This is a low-grade IPMN, but similarly, you can also get an adjacent high-grade pannin in the same patient. So again, this is a field defect, and we must recognize that cysts in these patients are different in significance compared to the average non-familial patient. And so the significance of these cystic lesions must be taken differently as when we actually look at the standard guidelines for managing pancreatic cysts. And this is important when we actually made recommendations for when to operate on our patients when we find these cysts, using the standard guideline recommendations for pancreatic cysts and IPMNs that are published and been used for many years. We also use the consensus guidelines that CAPS developed for operating on these detected cystic abnormalities. We published a study last year and showed that, in fact, these guidelines for operating, which are normal, like neural nodules, dilated duct, et cetera, don't really work that well. In fact, the sensitivity is quite low. Specificity is also suboptimal. So we clearly need to do better. We cannot, they're apples and oranges. Cysts in high-risk individuals do not mean the same thing in the average individual without symptoms who have IPMNs. So what are the challenges for pancreatic cancer screening in 2022? Really, I think it is to accurately select the detected lesions that we find for resection, meaning when to pull the trigger. It's really difficult to tell someone who has no symptoms, even though they have family members who died of pancreatic cancer, that they need to have part of their pancreas or even their whole pancreas removed. It makes me lose sleep at night. It's very, very difficult. The only thing you can do is make them worse with side effects of surgery, the threat of death. So it's really a big responsibility to recommend surgery in these patients. We have not perfected this yet. Also, we need non-invasive tests to complement annual imaging. Clearly, we have cancers that develop between annual visits and even biannual visits. And so the progression interval for PDAC is really not clearly defined. There's different phenotypes and subgroups. And so therefore, we need something else other than imaging to help us do better. When to operate, this is a problem. You can see here that this is a little nodule. It looked exactly the same as that early pancreatic cancer I showed you earlier. I was completely convinced this is a cancer. We biopsied this twice, and it was suspicious, cannot rule out cancer on cytology, on review. And it turned out to be, in fact, a false positive. You can create these pseudotumor nodules with these pannin duct precursors kind of close together and obstructing the ducts, causing atrophy and fibrosis and fat. And so therefore, this is now a known pseudotumor that we have to deal with when we find these small lesions that look like cancer. Some of these small hypoechoic lesions can also be neuroendocrine tumors that we also find incidentally. Those we typically can biopsy and document preoperatively. And so I want to show you now what the impacts are of our screening and research over the years. So this is an example again of a patient from years ago. She had a baseline low risk IPMNs. Here's an example of her MRI showing a cyst in the head of the pancreas, and she had multiple other cysts distributed throughout her gland. And so therefore, this is someone again that you really worry about. Do I need to do a total pancreatectomy? What am I going to do to impact her life and her quality of life? She actually had what we thought was multiple branch duct IPMNs. They were all small. But later on, she actually had first a distal pancreatectomy because we were worried about her. She had low-grade pannins, and on her completion pancreatectomy, 4 to 5 years later, she had multiple high-grade pannins, 10 of them, that each one of them could have become a ductal adenocarcinoma. And so we felt that we actually intervened just in time, just by luck almost. And so here she is 9 years after completion. She's now, I think, 15 years out from her total pancreatectomy. She says, I feel great. I never realized how depressed I was until after my operation. I am so relieved. I have to write a book to help other patients go through this. She hasn't written it yet, but she's promising. But it's clearly that we impact on patients' quality of life, and the whole, I guess, mostly surgical concern about total pancreatectomy nowadays, I believe, with the advances in diabetes management, et cetera, education are actually not as great as they were 20 years ago when we started this. So how to operate, what type of operation to offer patients, particularly with diffuse disease, with a field defect related to genetics, is really what we, again, need to put our finger on. And nowadays, when we do something to find something, we need to decide what to do with that when we, without impacting the patient. So clearly, this is, again, another direction we have to take. So this is that surgeon I told you about who had a total pancreatectomy. He had one cancer, which is in the body of the pancreas, but he opted for a total pancreatectomy. This was from, I think it was 3 years ago, before COVID. And he said, hi, folks. He gives us an update every year. 6 years ago, this time, this is actually longer than that, sorry. I was in the OR at Johns Hopkins quite a day. I have done well since, surviving, more than surviving, thriving. We did a 6-day, 140-mile bicycle tour of Normandy and Brittany, France in September. Wonderful, forever grateful. So he sends us these emails with pictures every year. And it's really amazing, again, that you can actually detect these early cancers and have high quality of life after surgery. This is another success story. This is someone, again, who progressed from a branched IPMN, clearly visible in early imaging studies, to a cancer in 8 years. A success story. She had a sister and a father who had pancreatic cancer, no known mutation. She had multiple cysts, again, a very typical phenotype with chronic pancreatitis on EUS, then developed a mildly dilated pancreatic duct in the head of the pancreas, no clear obstruction. No clear obstruction. This is what worries me the most, because clearly there is something there that we cannot see. And therefore, I know it's there, but I haven't yet found it. We actually need to do better on this, because in fact, when we recommended a follow-up imaging in short period of time, guess what? Yeah, now she has an obstructive cancer, which we then diagnosed. This is an IPMN-associated ductal cancer. You can see the evolution from a benign branched duct IPMN to a full-blown cancer. And ideally, we shouldn't have let the cancer develop. We should have done a Whipple before, ideally, it developed and we could see it. But again, we still don't have the tools to figure that out in current time. So again, prevention more than just early detection is what we need to improve upon. And so here are the two Whipple sisters. The patient I showed you, alive and well, no evidence of cancer 4 years later after her Whipple, and her other sister who was detected much early in our CAPS program, 8 years later, and they're both alive and well. They call them the Whipple Sisters. So again, this is a very nice outcome from the screening study. So I want to show you the real data of the outcomes. So we have shown now that screening leads to greater resectability and stage shift. So this is the comparison of our surgical patients who actually had PDAC detected in screening, 72% in this early series and 90% even later series, compared to what we know in SEER, which is most patients are not, this is Johns Hopkins. Most patients even referred were not resectable when they had a PDAC. You can see here also the stage shift with more stage 0 carcinoma in situ or high-grade disease being detected in screening, and more metastatic lesions in the SEER patients who were diagnosed with PDAC. When you went on, we presented this in DDW just recently to do a matched control study using SEER data, because you may argue that there's some selection bias, et cetera. You can see here that the results are the same in terms of a stage shift. 61% of the screened PDACs, these are known PDACs detected in screening, were local, therefore potentially curable or at least treatable. More were regional, and certainly far more were, this is 6.1%, not 61%, were metastatic. So it's clearly a shift to an earlier stage in detected cancers, even with matching and adjusting for all types of parameters. And when you look at the actual AJCC stage, again, 50% were stage 1. I'm going to say that again. 50% were stage 1 disease in our screened PDACs, and therefore this is a phenomenal outcome that you're not going to see unless you actually have this type of targeted specific surveillance program. So here are the Kaplan-Meier curves. We showed this in the gastro paper earlier, where you have a 3-year overall survival. 100% of the patients with high-grade dysplasia but no cancer were all alive at the time of the analysis. Most of the patients were alive at least 3 years, compared to those who did not, who fell out of screening or did not comply with screening. And you can see here that 85% 3-year survival is unheard of in oncology trials. compared to 25% in the general, resected, treated PDAC. We know clinically. And here's the 5-year overall survival, again, 60% alive 5 years in patients who were detected in screening programs. And so again, in our matched SEER study, which was presented, adjusting for all kinds of parameters that affect survival, like year of diagnosis, gender, age, tumor location, et cetera, you could see that the results persist, that there's clearly a benefit in survival in CAPS patients compared to matched SEER patients that are also comparable to the eligible SEER PDAC patients that are reported in the United States. So again, this is not lead time bias. A systematic review of all the published studies also reinforces this notion that there's a higher curative resection rate, a longer average survival time, and more stage 1 PDACs found in high-risk individuals undergoing surveillance compared to those who do not. And EUS diagnosed at least almost 2/3 of those pancreatic cancers that were published in these studies. So now that we're in 2022, how can we improve early detection and prevention? Well, you must have heard, some of you, about liquid biopsy or blood-based biomarker approaches. Well, there's several of them. There's detecting proteins, circulating tumor cells, exosomes, circulating DNA, ctDNA, cell-free DNA or cfDNA in blood. And this would be, again, the holy grail, right? Because take a blood test and find cancer. And in fact, we are closer to this. It's actually amazing how much progress we've made all these years. I'm going to just give you a preview of what progress there's been. So we have available blood tests, right? So now we have the fasting blood glucose and hemoglobin A1C. We can diagnose new onset diabetes, which we know has some small risk in patients who've been diagnosed 2 years before their pancreatic cancer is diagnosed. So we have an opportunity in new onset diabetics to potentially find cancer. We also have what we've been using for many years, the serum CA19-9. It's a glycoprotein related to the Lewis blood group antigen. It's clinically available, but it's not really very good for pancreatic cancer screening. It has poor sensitivity, poor specificity, false positives. So we use it more to detect response to therapy. It goes down after surgery, goes up when patients recur, and that's how we currently use it clinically. But our group, particularly Mike Goggins and his lab, actually proved that there are genetic variants that affect circulating levels of CA19-9 that actually I didn't know about before we did this study. So if you have a certain genotype, there are 3 subgroups. When you have null, et cetera, or FU23, you can see that the range for abnormality of CA19-9 can vary. And so this concept of personalized CA19-9 cutoffs is in fact now something that we are clinically using at Johns Hopkins. This is a clinical blood test that we have now at Johns Hopkins that we're using particularly in CAPS patients when we genotype them to see. This is the reason why some patients who are null for this gene may have a normal CA19-9 even though they have cancer. This is part of the reason why that is. So in fact, this is one strategy. When we looked at study this to try to validate it, you can see that it does improve the sensitivity and specificity. It's not perfect again, but still a little bit better than doing nothing. And then the other blood biomarker screening tests that we know about, again, I'm just listing some of them here. These are new in the last 5 years, and I want you to know about them because this is where we're going to move in that direction in this next decade. So I just want to go through this very quickly. There's the hydroxymethylcytosine assay by Blue Star Genomics. There's CancerSeq, currently licensed by Exact Sciences, which was developed at Hopkins. These are multi-cancer screening blood tests. There's the GRAIL Pathfinder test made by Galleri. And then there's a single pancreatic cancer specific blood test called MRI PanCan-D by Immunovia. And I'm going to show that to you just preliminarily. The Blue Star Genomics test is FDA approved, but not yet clinically validated. I'm going to say that it's not yet clinically validated. You actually can send the test. The patients can actually order the test for themselves, but it's again not been validated. So it relies on hydroxymethylcytosine signatures in cell-free DNA that are detected. And so their current target, and this is what they're studying in their trials, is pancreatic cancer in new onset diabetics in patients greater than the age of 50. They have not yet studied this in patients with a high risk. In the GRAIL study, it's methylation analysis for cell-free DNA. And in this one Pathfinder study that they published in more than 6,000 individuals, they found all kinds of cancers, breast, colorectum, liver, bile duct, et cetera. So again, multi-cancer in a single blood test. It's very interesting. There are 29 cancers. The overall stage 1 to to 2 cancers actually is quite significant. We'll have to see if this really pans out. But again, there's some benefit in diagnosing other cancers that would not otherwise be detected with normal screening, right? Then there's the CancerSeq. It's developed at Johns Hopkins with Bert Vogelstein's lab. So initially 8 genes, now it's 16 genes circulating DNA plus proteins. So it's evolved. Again, currently licensed now by Exact Sciences, and they are conducting all the studies. But it can detect cancers from 10 organs, including 7 which have no recommended standard of care tests, including cancer of the pancreas. And so the initial trial that Dr. Lennon, my boss, conducted in 10,000 women called the DETECT-A study, detected 26 cancers, none were pancreatic, but now they're in the second and third study that is moving forward with clinical validation to see what the actual yield is for other cancers. And then there's the pancreatic cancer specific multiplex antibody-based biomarker assay, IMRA, which is supposedly for the detection of early stage pancreatic ductal cancer. It uses 8 protein biomarkers plus CA19-9. So it adds CA19-9 to these biomarkers in this specific array of antibody using supposedly a signature microarray profile. And this is the one study already published by Randall Brand and his group, multicenter. This is now, if I want to point out to you, it's an international study using a case cohort control design, but this was kind of stacked with a lot of ductal adenocarcinomas, including stage 1 and 2. So the prevalence of cancer was pretty high in this case control study, but nevertheless, they also had healthy controls, including familial and sporadic pancreatic cancers. So you can see here, very exciting, again, to be validated, proven 89% sensitivity overall for stage 1 and 2 pancreatic cancer. That's pretty exciting. 92% sensitivity overall for all stages of pancreatic cancer. Again, whether this is too good to be true. And look at the specificity, 99%. So this is where the FDA wants us to be. They want this to be so specific that we are not going to have a lot of false positives in healthy individuals who are undergoing this test. Again, this is just first publication out, but pretty exciting. Here's the AUC curve. Again, just stay tuned for more results on this, because this, again, is something that's never been. We've never had a pancreatic cancer specific blood test that can show these kinds of results. So in summary, I wanted to show you that the accumulated evidence to date worldwide supports screening and surveillance of high-risk individuals, and it's beneficial. These liquid biopsy tests are promising, but clearly we need more data. The cost needs to go down. Each test on average costs about $1,000. Some patients are actually ordering these tests for themselves and paying for them out of pocket. And so this actually obviously is not feasible or logical. The priorities for research in the future, again, as I mentioned, are prediction of risk and progression, more selective surgery so we can do better, artificial intelligence to use this approach to help us analyze all different factors and imaging features to detect really subtle lesions, early lesions, and precancerous high-grade lesions. And so now is the time. So I want to thank you for your attention, and I can take any questions.
Thank you so much. Again, thank you, Dr. Canto. That was an outstanding talk for a devastating disease. You give us some hope in terms of what we can do for your patients. And I love the story of the Whipple Sisters. This goes back to, again, our theme of personalized medicine. I think for me, you brought up something that is, an important and ethical question, because already patients have the opportunity to order these tests. We don't really know what to do with that information. You mentioned, these multi-cancer tests potentially can create a lot of anxiety and stress because they'll have a positive result. We don't know how to, other than doing some imaging or potentially endoscopy, we don't know how to alleviate that stress, especially if the tests are negative, and trying to convince a patient that they had a false positive on one of these genetic tests. What is your recommendation when you talk to a patient potentially as high risk? Like you mentioned, a patient that has new onset diabetes. Are you encouraging patients who have not new onset diabetes to have some sort of, if they don't have any other kind of explanations for their diabetes, how do you explain to a patient that you're encountering the fact that some of these things are not yet ready for prime time?
Yeah, so thanks. Really, really great question. I think there's 2 parts to your question. One is the the multi-cancer tests,
Yeah.
what to do with that. We just still like basically tell patients, not ready, don't do it. We just don't know. In trials, there's several trials on clinicaltrials.gov that you'll see. There's one specific NOD for new onset diabetes, and there's this whole group on new onset diabetes looking at biomarkers and what the yield is. If you look at all NOD patients, it's only if you screen 10,000 NOD patients, only 1% of them who fulfill the NOD criteria, just in general, will have pancreatic cancer. Now, when you increase that and put what we call a filter, which you add age and et cetera, other risk factors, so that's called the NPAC criteria, then you can increase it to 3%, but it's still pretty low, right? You have to screen thousands and thousands of NOD patients to get so many pancreatic cancers. So that's one thing. And so maybe, as I mentioned, the Blue Star Genomics study is trying to add liquid biopsy to that in terms of NOD patients. So we'll have to see if in fact that makes that yield of screening NOD patients better. And that's not just for genetic people, that's all people NOD in population-based screening studies. So in terms of using those multi-cancer blood tests, it's crazy. Like, we have patients, and of course you can understand, they're worried, they have family members who died, and they'll take anything, they'll pay out of pocket to get these tests. But I think we have to just do a good job of, the FDA obviously is going to have to look at these and tell people that this is not yet approved, don't do it yet. But yet these labs are offering these tests for even physicians and patients to order. And so they have to be really cautious about this. And I think it's not just going to add to their anxiety to not know where why it's positive, because there's so many cancers that could possibly have. In the CancerSeek trial that I told you about, they had to do like a whole algorithm of PET-CT, colonoscopy, EGD, all the other imaging tests to find those cancers. And they did find them, but still, I think it's jury's still out on what place it is in our practice.
Thank you so much. We'll take one question, then we'll get to our award.
Thank you, Dr. Canto, for intriguing talk. I had a patient 2 months ago with referred to me for double duct sign and a mild episode of acute pancreatitis. He has a brother with a history of who died of pancreatic cancer. Long and behold, I did EUS, ERCP on him, and he had an ulcer at the ampulla. The biopsies came back as adenocarcinoma. I actually saw him in the clinic on Monday, and a little bit of promotion to UCI. He just had his Whipple at UCI. So as they're walking out of the door, his wife asked me if they're interested in genetic testing. So this is again, the pancreas on EUS looked normal. Is this a patient that you would send for any genetic testing? And if so, what kind of testing?
So just to clarify, he on pathology had an ampullary adenocarcinoma or a pancreatic?
It looks ampullary on the path.
Okay. So
yeah, and it's a clearly ugly looking irregular ulcer at the ampulla.
yeah, so I don't know about ampullary adenocarcinoma and hereditary pancreas. But if is it the brother who had
His
cancer?
brother died of pancreatic cancer, and actually when he first was coming and stepping into my office, his main concern was pancreatic cancer.
Yeah, so I think what I would recommend is still, I agree, would be genetic testing with full counseling. It's actually easy nowadays, like it's spit into a cup and send it back in the mail. We use 3 different ones and a full like 32 panel gene. It's easy because if you're negative, which most people are, and even when you have 1 first degree relative or 2 or another remote relative, then you don't need to do anything. But when it's positive, then you have to go through genetic counseling to kind of discuss what it means and what it means for their surveillance, because if it's a BRCA gene, then you have to go breast cancer and ovarian and all that. So it has implications for their management. But again, with just this ampullary with a single pancreatic cancer, even without the ampullary cancer, I don't know if it's really related. I would still support genetic testing.
Which genetic testing do you order? Which
we use either Invitae or Color or forget the other one. There's 3 of them. Yeah, and they're all very easy. You can go online and order them.
Thank you.
Yep.
Great. Thank you so much, Dr. Canto.